Hello friends, today we learn about chronic renal failure in case of pediatrics. Chronic renal failure, more commonly known as CKD or chronic kidney disease, is a permanent progressive decline in kidney function, characterized by structural abnormalities or functional impairments present for over 3 months. Chronic renal failure affects nearly 5,000 per 1 million population per year. 1% to 2% are in the pediatric age range. There are different causes for CRF, which we discussed with the pathophysiology. Next, the pathophysiology of chronic renal failure. The ecological factor, a severe case of acute kidney injury or AKI can lead to chronic renal failure or CRF. The etiology of AKI or acute kidney injury is prerenal, increasing or intrarenal and postrenal, and there are also the other causes for the chronic renal failure. So first we learn about the etiology of AKI in prerenal failure. In prerenal cases, the hypovolemia. In case of hypovolemia, there are hemorrhage, dehydration, excessive loss of GI tract fluid, excessive loss of fluid due to burn injury, nephrotic syndrome or septicemia. Next, decrease the vascular filling, anaphylactic shock and septic shock, and also causes for the heart failure and cardiogenic shock, and due to decreased renal perfusion due to vasoactive mediators, drugs and diagnostic agent and perinatal asphyxia. And in case of intrinsic or intrarenal failure, acute tubular necrosis, prolonged renal ischemia, exposure to nephrotoxic drugs, heavy metals, intratubular obstruction resulting from hemoglobinuria, myoglobinuria, acute renal disease like AGN or acute glomerulonephritis, pyelonephritis and hemolytic uremic syndrome. Next, in case of postrenal bilateral urethral obstruction, bladder outlet obstruction, neurogenic bladder, Wilms tumor or structural anomalies or calculi. Next, in case of the other cases, the congenital anomalies like the PKD, polycystic kidney disease, bilateral renal dysplasia, glomerulonephritis, SLE or systemic lupus erythematosus, pyelonephritis, obstructive uropathy or storage disease like the amyloidosis and Alport syndrome and bilateral Wilms tumor. Due to these all causes, there are decreased renal blood flow and primary kidney disease occurs, damage from the other disease also and urine outflow obstruction, and due to all these causes decrease the glomerular filtration rate, and due to decrease the glomerular filtration rate there are increased the serum creatinine level and increase the burn or blood urea nitrogen. Due to the decrease the GFR and dilute the polyuria, there are hypertrophy of remaining nephron are seen, and for this there are loss of sodium in urine and hyponatremia are seen, and for the dilute the polyuria ultimately dehydration also occurs, and due to hypertrophy of remaining the nephron there are inability to concentrate the urine and further loss of nephron function. Due to the loss of nephron function there are loss of non-excretory renal function are seen and also loss of excretory renal function are seen. Due to the loss of non-excretory renal function, there are failure to convert inactive forms of calcium, and for this reason there are calcium absorption are seen, so hypocalcemia and osteodystrophy occurs, and failure to produce the erythropoietin, there are anemia and pallor are seen, and impaired insulin action, there are erratic blood glucose levels are also seen. Due to the increase the production of lipid, there are advanced atherosclerosis may occur, and due to the immune disturbances, there are also the delayed wound healing and infection are seen, and due to the disturbances in reproduction system, there are libido and infertility may occur. Next, in case of loss of excretory renal function, there are excretion of the nitrogenous waste. For this reason, there are uremia occurs. So, they increase the burn, creatinine and uric acid level. Proteinuria also seen, and peripheral nerve changes, pericarditis, CNS changes, pruritus, altered taste and bleeding tenderness are seen. Next, decrease the sodium reabsorption in tubule and water retention. Due to the water retention, there are hypertension, heart failure, and edema are seen. Due to the decrease the potassium excretion, there are hyperkalemia occurs, and also decrease the phosphate excretion and hyperphosphatemia. In decrease the calcium absorption, so the hypocalcemia seen, and hyperparathyroidism also occurs, and decrease the potassium excretion and increase the potassium level, and also decrease the hydrogen excretion. For this reason, there are ultimately the metabolic acidosis are seen. The clinical features of chronic renal failure: increased thirst, frequency of urination, anemia, rickets, growth failure, joint pain, muscle weakness, peripheral neuropathy, acidotic breathing, and anorexia, nausea and vomiting, itching, purpura, and hypertension, pericarditis, heart failure, and electrolyte disturbances. And there are also the hyperparathyroidism seen and osteodystrophies. In case of diagnostic evaluation, there are urine analysis. In case of the blood test, there are complete hemogram, electrolytes, blood urea nitrogen and creatinine, and bone radiograph and Viking cystourethrogram are checked. The treatment of chronic renal failure: in case of the diet, the restriction of the salt, fluid, protein, phosphorus and potassium is recommended. Daily intake of protein can be 1.5 gram per kg per day. Calorie intake should be 80 to 100% of our day. Recommended dietary allowance. Treatment of acidosis, sodium bicarbonate are given, and treatment of anemia, there are packed red cell transfusion and human erythropoietin given, and treatment of hypertension, the anti-hypertension therapy are given, and in case of the renal osteodystrophy, there are low phosphate diet with antacid, vitamin D3, dialysis, and lastly the renal transplant are recommended. In case of the nursing management, the planned approach are: provide the fluid as ordered in different phases of illness, maintain the strict intake-output chart, do not overhydrate the child, watch for edema or dehydration, measure daily weight and blood pressure, monitor burn, creatinine and potassium level, administer diuretics as prescribed. Provide salt-restricted low-protein, phosphorus and potassium diet. Provide food as per choice of the child. Offer small and frequent feeds. Provide recombinant the growth factors as prescribed. Observe for sign of infection. Provide good skin care and frequent turning. Allow loose the clothing to wear. Adjust the child's activity as per tolerance level. Provide the restful environment and encourage the child to attend the school and age-appropriate activities as tolerated, and provide all necessary information to the parents regarding the disease, treatment, outcome and dietary restrictions, and prepare the child and family for dialysis.